thing, you sitting there and have a red light.
Alright. Take number 357. Alright. My name is Caleb Collins. Today we're going to talk about the mechanical and electrical systems of the heart and how to treat unsustainable rhythms. The objectives of this PowerPoint is going to be, by the end of this presentation, the viewer should understand the mechanical systems of the heart, the electrical conduction system, baseline rhythms that are interpreted out in the field, lethal rhythms that can be identified in the field, and the treatment plans for those unsustainable rhythms. For the mechanical system of the heart, in order for you to understand the way it works, the first thing you need to know is the different mechanical parts that are inside of it. To start everything off, you have two atrium that are going to be your top two chambers. You have two semilunar valves, which is your pulmonary and aortic valve. You have two in-between chamber valves, the tricuspid and the bicuspid or mitral. You have the right and left ventricles and your ascending and descending aorta. As for the right side of the heart, as you can see over here, you have your right atrium, your tricuspid valve, and your right ventricle. The right atrium is going to consist of the blood coming from the body that's already been circulated. It's going to come in through the superior and inferior vena cava. The blood goes through the tricuspid valve back into the right ventricle, and it's sent out by the pulmonary artery back to the lungs in order to be reoxygenated. The left side of the heart receives that blood that's been oxygenated from the lungs through the pulmonary vein, which is not listed on this slide, but I'll show you on the next one. It comes back in through your pulmonary veins, and it goes into your left atrium. It goes through your mitral valve and into your left ventricle. Your left ventricle is your heart's powerhouse. It's what's going to pump the blood to the rest of the body, to your extremities, your head, pretty much everywhere it needs to go after it's been oxygenated. And it comes right up through here in the aortic valve and comes out through your ascending aorta, and you also have a descending aorta. So for your blood flow checklist, you have your superior and inferior vena cavas that I talked about on the last slide, here and here. When they come through there, they come in here into the right atrium. Oh, I forgot to erase. That's okay. They go into the right atrium, and they're going to come through this tricuspid valve right here and into the right ventricle. Goes up into the pulmonary artery, and you have a right and left pulmonary artery. The exits here and here. Both of those go to lungs. And after it goes into the lungs, it reaches the alveolar level, gets reoxygenated. They start coming back through these veins that are listed on the right pulmonary and left pulmonary, and they come in here into the left atrium. After they enter the left atrium, they're going to come right here through the bicuspid or mitral valve, and they're going to come into the left ventricle. When the left ventricle goes to pump, it comes through here, which is going to be your aortic valve, goes up and comes through your ascending aorta, and then it comes down through here in your descending aorta. And for a lot of people who get confused with what order the valves go in, one thing you can do is TPMA. Tricuspid, pulmonary, mitral, aorta. All right, now that we got the mechanical system out of the way, let's talk about the electrical conduction system. So the electrical conduction system is going to be a bundle of nerve fibers that go around your heart that do exactly what they say. They have their own impulse to create an electrical conduction for your heart to beat. The conduction and the mechanical system have to work together for the heart to beat. So for your first one, you got your SA node, which is also the sinus node. This is going to be the primary pacemaker of the heart. This is going to be for all your regular rhythms that you're going to find between 60 and 100 beats per minute. Your AV node is going to be right here at the end of these internodal pathways. The AV node is the node that sits in between the four chambers of the heart. So let's say you have your nerve fibers right here, but if you wanted to put it all together, we'll just draw a circle right here, try and break it up a little bit. So we'll go here, and we'll go here. So we'll say this is the right atrium, this is going to be the left atrium, right ventricle, left ventricle. So your SA node, which is right here, primary pace comes all the way through. And your AV node, this is in the middle of the four chambers, it's kind of like a stopping point for a second. And then your impulse is going to go through your AV bundle, which comes down into your bundle branches, and ultimately that's what causes the rest of the heart to contract. With your AV node, is only going to make a primary beat if the SA node fails, which is going to give you a beat of about 40 to 60 a minute. And if you ever go down to your bundle branches and your Purkinje fibers, your heartbeat's going to beat at a range from 20 to 40, and that's going to be your ventricular rhythms. Getting into EKG readings, we just talked about the electrical conduction system. So this is what it's going to look like when you put the pen to paper, so to say. So an EKG is consisted of a P wave, a QRS complex, and a T wave. Your P wave is going to represent your atrial depolarization. When that SA node fires and those atriums contract, you're going to get this little bump right here, and that's called a P wave. Your PR interval is going to be the time between your atrium and your ventricles depolarize. So from the start of your P wave, right here, all the way up until you see this little line right here, that's going to be your PR interval. Normally a PR interval is going to be 0.20 seconds to less. And we'll get into that when we go over EKG strip readings. Your QRS complex is going to represent your ventricular depolarization. And as a side note, your atrial repolarization is hidden in the QRS complex. So this complex right here, we'll draw down this dotted line. That is going to be where your ventricles are depolarizing. The reason that EKG reading is so much taller than a P wave is because your ventricles are more muscular than your atriums are. They have more force projected behind them when they pump all that blood out. You've got a T wave in the back that represents your ventricular repolarization, which is found right here. That's when your ventricles are filling back up with blood and getting ready to pump again. And your QT interval is going to represent the time from your ventriculars depolarizing to when they start to repolarize. Parts of EKG strip paper. So normal EKG strip paper is going to be about yay thick, and it can be however long you want it to, depending on how long you want a rhythm strip to be. What it's consisted of, it has different measurements that you have to realize. So you have these little boxes right here. You measure them in height going up and down, and you measure them in time going left to right. If you're going from left to right, they're going to be at 40 milliseconds per box. So you have 1, 2, 3, 4, 5. And then if you have a whole box of 5, is 0.2 seconds. When you're measuring in height, it's measured in millimeters. So you got 1, 2, 3, 4, 5, which is a total of 5 millimeters per box. It takes 25 small boxes, which are these right here with the dots, to fill up one big box. For calculating the heart rhythm, you're going to take your strip paper, and you can use two different ways. You have the 300 method, which is count how many of the big 5x5 boxes are between two R waves, and you're going to divide 300 by the number of boxes you found. So, for an example, if you're counting your boxes, and say there's 4 big boxes in between two R waves, you're going to do 300 divided by 4, which is going to equal up to 75. Another way you can do it is a 6-second method. And how you're going to do that is you're going to count out 30 of the 5x5 boxes and count the number of R waves and then multiply them by 10. And you can also use the 6-second method for irregular rhythms. So the first rhythm we're going to go over is the one rhythm everybody should know. This rhythm is going to be your regular normal sinus rhythm. Normal sinus rhythm, it consists of symmetrical P-wave morphology. And what that consists of is these little bumps that's in front of each QRS complex. They're going to look identical. And as you can see, none of them look any different. You're going to make sure that PR interval is 0.20 or less. So you're going to measure from the beginning of your P wave all the way to your QRS complex, and you're going to count your boxes. And we got 1, 2, 3, 4. Which is equal to 0.16. So it's less than 0.2. You're going to make sure your QRS complex is going to be less than 0.12 seconds, which means it's going to be less than 3 boxes wide. So if you're looking at it right here, you start your QRS here, and it ends here. And 1, 2. So 0.08. So that is a normal sinus rhythm. Everything is following in the guidelines of how to make sure it is sinus. Next, we've got sinus bradycardia. So sinus bradycardia is going to be a little bit of the same of what you have with your normal sinus rhythm. We're going to have our P waves again, 1, 2, and 3. They all look the same. They're all symmetrical. Cool. Next, you're going to measure your PR interval again. Come back to the beginning of your P wave. Measure to the QRS. We got 1, 2, 3, 4, 5. This time we got a PR interval of 0.2, which is sinus rhythm. The only difference is going to be that your heart rate of this rhythm is going to measure below 60. So normal sinus is going to be 60 to 100 beats a minute. Sinus bradycardia is going to be slower than 60. Next up, we got sinus tachycardia. Sinus tachycardia consists, again, of the same PR interval, P-wave morphology, and QRS complexes. As you can see, you got a P-wave, QRS, P-wave, QRS, P-wave, QRS. Every P-wave has 3 boxes in between, or 4 boxes, 4 boxes in between the start of the P-wave and the start of the QRS. So we're back at 0.16 for a PR interval. All of our QRSs are smaller than 3 small boxes. And the next difference is going to be, this heart rate is going to be above 100. And this will be a good place to show you how to do that 6-second strip. So if you see these 3 lines up here on ECG paper, normally what that tells you is that there is 3 seconds in between 2 dots. If you have 3 dots, that means you have a 6-second strip. But at the same time, it could have been a manufacturer error. Those dots could be wrong. So we're gonna go ahead and count out our 30 boxes and we're gonna figure out our heart rate. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. So we got our 30 boxes, so we got a 6-second strip. Next thing we're gonna do, we're gonna count each point that is inside of this strip. So we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. All right, so you have 13 points inside of a 6-second strip. Well, 6 seconds, how many seconds are in a minute? 60. So what do you multiply by 6 to get to 60? 10. So roughly what your heart rate should be in a minute is whatever this number multiplied by 10 is going to equal. So we had 13 times 10. Your heart rate for this heart rhythm is going to be 130, which is above 100, which shows it's sinus tach. Anything above 100 beats per minute is going to be considered under sinus tach. So I have a few strips right here, and what we're going to do is we're going to find the regularity, rate, PR interval, QRS duration, and we're going to name our rhythms. So for this top rhythm, we're going to look at it. We're going to count our boxes. We got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 1, 2, 3, 4, 5, 6, 7, 8. All right, so this is going to be a 6-second strip. We got our 30 boxes at the bottom. Awesome. Now, I know I didn't cover it, and you're about to ask me how to find regularity. The regularity is going to consist of how many boxes are in between each point. So, we come up here, and we have 5, 10, 15. Got 19 boxes here. Regularity is going to be defined as how many small boxes are in between each R wave. So you can normally vary maybe one higher or one lower, but you don't want to get anything too high out of whack, or else it's going to be an irregular rhythm. So we have 19 here. We have 5, 10, 15. 1, 2, 3, 4. We got 19 there. Then we got 5, 10, 15. And we got 20 here. So it's going to be based off of 3 different R to R intervals. And we got 19, 19, and 20. So this rhythm is going to be regular. Your PR interval from the start of your P wave, which is right here. Got 1, 2, 3, 4. So 0.16. So the PR interval is below 0.20, which means that it is a sinus rhythm. So the next thing we're going to do, count our lines. And we have 1, 2, 3, 4, 5, 6, 7, 8. 6-second strip, 8 points. 8 times 10 equals 80 beats per minute, which is going to mean that this is going to be normal sinus rhythm. For our next one, this one's a little bit harder to see all the boxes, but we're going to go based off of our little notches. So we got 1, 2, 3. We're going to say that's going to be 30. All right, for our PR interval, it looks like it starts here. Then we got 1, 2, 3, 4 again. So 0.16, which means it is a sinus rhythm again. Count our R waves. We got 1, 2, 3, 4. 4 times 10 is 40 beats per minute, which means this is going to be sinus Brady, because the heart rate's going to be slower than 60. And for our next one, we run into the same problem we did with the last one. I'm gonna have to talk to the man who's picking out these slides. I don't think he did too good of a job. So we got 1, 2, and 3. So we got that. Check our PR interval. Starts here. Then we got 1, 2, 3, 4. Again, 0.16. Got our 30 boxes. Got a 6-second strip. Count our R waves. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So I'll write this over here. 12 times 10. That's going to be 120 beats per minute, which means we're going to be in sinus tachycardia because that heart rate's going to be above 100. All right, let me get these other dots out of here real quick. So we talked about sinus Brady, sinus tac. Now let's get into a rhythm that's a little bit normal, and it's going to be an irregular rhythm, which is atrial fibrillation. This is going to be a sinus rhythm where a lot of times the P waves are going to be undefinable. You can see that there's something there, but you don't know what it is. A lot of people live with atrial fibrillation every day, and it can be corrected with being compliant with their medications. So when it is in rates of higher than 150, that's when it's time to start taking interventions. If we're working on the truck, if we're working in the hospital, if we're working at a doctor's office, the heart's only going to sustain heart rates of very high for so long before it ultimately crashes. So right in here, and you can see in between all your R waves, you've got little squiggle lines. What that's consistent of, that's going to be your atrium, but instead of it making one full beat, it's sitting there and it's shaking. Just like what it says, it's fibrillating. So we can't find a P wave in here. So we're not even going to try to find a PR. What we are going to do though, is we're going to measure our regularity in between our R waves. So let's see what we got here. We got we have 1, 2, 3, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. All right, so we got 10, 13. Next one, we got 1, 2, 3, 4, 5, 1, 2, 3, 4. We have 9. Well, we just talked about anything with a greater difference than 1 or 2 isn't going to be regular. We'll go ahead and count the third one. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2. So 13, 9, and 17. Obviously, this isn't going to be a regular rhythm. So we're going to say this rhythm is going to be irregularly irregular, which means that no matter how long this rhythm goes on, no R to R interval is going to repeat itself. It's always going to be irregular no matter which way you look at it. So let's go ahead and find out what our heart rate is. We don't have no line, so we're going to have to count our boxes. We got 1, 2, 3, 4. I don't have enough boxes. And we can't use our 300 method. So what we'll do is, let's see how many we have. 1, 2, 3. Nope. Can't find the heart rate on that one. What we'll do is though, we'll go into talking about the treatment of AFib. So, in cases of having a stable patient with AFib RVR with a heart rate that's higher than 150, first attempt, you can go and you can try a fluid bolus. Sometimes AFib is the result of a fluid problem inside of the heart. The heart's not getting enough fluid, it's trying to quiver, it's trying to pull blood, it's trying to push it back out. If it doesn't convert with the fluid bolus, cardizem or diltiazem, which is a drug of choice that can be found on the ambulance and most services, can be used. Your dosage for that is going to be a loading dose of 0.25 milligrams per kilogram up to 25 milligrams. Normally, the value you find on the truck is going to be a max of 25 milligrams. If you have an unstable patient, this is going to be your patient complaining of chest pain, shortness of breath, going in and out of consciousness, you know, anything that can seem to be life-threatening, cardioversion may be necessary. So for a narrow and irregular rhythm such as AFib, it is recommended to do 120 to 200 joules of synchronized cardioversion. If unconverted, you can increase the joule settings until the max listed, which is going to be 200, has been reached. Next, we're going to talk about supraventricular tachycardia. This is going to be any fast heart rate above 150 that is narrow, because you can tell it's above the ventricles. So when presented with these patients, it's going to be an SVT. It's important to know the treatment plan to follow. If you have a stable patient, which means they're an SVT, they're sitting there, you know, they're not really short of breath, they're not complaining of anything, you can try vagal maneuvers first. You can tell them that they need to bear down. You can hand them an empty syringe, tell them to blow the plunger out the other end of it. If those ultimately don't work, we'll go down our treatment route with our medication of administering adenosine. It's going to be a 6 milligram rapid flush. Make sure that you have an IV no lower than an AC, because the half-life of adenosine is only 10 seconds. So as soon as you get that 6 milligrams in, you need to flush with 10 to 20 mLs of saline to go ahead and push that medication through. And if that doesn't work, you can follow it with a dose of 12 milligrams. And if you're presented with a patient that is in immediate need of rhythm converting, you can also consider cardioversion as listed with AFib on the prior slide. Atrial flutter is another atrial rhythm consisting of narrow QRS complexes. The only difference is you're not going to be able to find P waves in here because of this sawtooth pattern. And as you can see here, you've got these points and then you got a QRS. You got a point, QRS. So right here, this would be A flutter in a 2-to-1 ratio. Normally your treatment plan is going to follow that of afibrillation. Sinus block, pause, and arrest. Sinus block pause and arrest are sinus rhythms in which the SA node fails to make an impulse to send for the heart to beat. It will be characterized by looking like a sinus rhythm with missing beats. In sinus block, it will look as if you can take a full heartbeat and place it into the area that the beat is missing from, and the rhythm's going to look normal. So it's going to look like I just grabbed it, took it out, and it just kept going. Sinus pause is when you have a pause long enough to take up to 2 beats and place them in an R-to-R interval that's going to be a multiple of the initial R-to-R. Which means if you have an R-to-R of 14, if you're missing 2 beats, you should be able to plug 28 blocks into that block. Sinus arrest is going to be a pause that's going to last up to 3 seconds or longer. Junctional rhythms. Your junctional rhythms are going to consist of a little bit different aspect than sinus rhythm. Your P waves are going to be asymmetrical, which means that they aren't going to be, you can't cut them in half, you can't fold them over. They could be inverted, which means they could be upside down, or they might not be there at all. Your QRS is still going to be less than 0.12 seconds, and they're still going to be regular and irregular. They're still going to be regular rhythms. So for your initial junctional rhythm, it's going to be 40 to 60 beats per minute. These junctional rhythms are coming from the AV node. So they're not coming from the top where the SA node's found. So right here is a little bit harder to see, but you can kind of make out that these heartbeats don't have a P wave in front of them. But you still got a narrow QRS complex, narrow QRS, no P wave, narrow QRS, no P wave, narrow QRS. And 30 blocks, 4 R waves times 10, gonna have a heart rate of 40, which is gonna be your regular junctional rhythms. Accelerated junctional is gonna be from 60 to 100. And we got our blocks again right here. And as you can see, it stated it right here, you got an absent P wave in front of the QRS complex. And that follows all these QRS complexes. And we got a heart rate of 1, 2, 3, 4, 5, 6, 7, 8, 80, which means we're gonna have accelerated junctional tachycardia, anything above 100. So again, absent P waves, narrow QRS complex. We got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We got 120. So above 100, that's going to be junctional tachycardia. Here's my sinus block pause and arrest slide. Should have been 2 slides over. So, flip back for me real quick. One more. All right. So back into this sinus block. Take a heartbeat out. We can plug it back in. Sinus pause. 2 multiples of the R to R. Sinus arrest 3 seconds or longer. We'll go over that now. So, here's our sinus block at the top. Here's where our P wave starts. Here's where our T wave ends. All right. So we got 1, 2, 3, 15, 16, 20. So 1, 2, 3, 20. Let's see. So if we were to plug a heartbeat into right here, this rhythm would look normal. Because your R's will match up. It just looks like we took a beat out. Sinus pause. You got your P waves again, T waves, P waves, T waves, QRS. Keep going, keep going. What we have right here is going to be a finding that we will talk about in a little bit. But as you can see, this is a little bit longer than what a block is. I can't just take one QRS and plug into here and it'll look normal. And your sinus arrest, which is down here at the bottom. So you've got your 2 lines right here, which is equal to 3 seconds, which means for 3 seconds the atriums have failed to fire, which leads to sinus arrest. Findings in heart rhythms. So right here we're going to talk about your premature atrial, premature junctional, and premature ventricular contractions. Your PACs are going to be found, they're going to look like a normal heartbeat, they'll be out of place, and they'll make the rhythm look all funky. Your premature junctional contraction is going to be found to look like a PAC, but it comes with the cost of having junctional morphology of P waves, which means they could not be equal, they could be inverted, or the P wave might not be there at all, again. And a PVC, which is your premature ventricular contraction, is going to be Y complexes that can pop up sporadically, just like PACs and PJCs. That can be compensatory or not compensatory. And what that means is if you're checking the heart rate on a patient, you can feel it pulsate, or it might not pulse at all. So, and another fun fact about PVCs, you can have them in different orientations, such as bigeminy, which is every 2 beats, or trigeminy, which is every 3 beats. So right here, you got a sinus rhythm, sinus rhythm, sinus rhythm, sinus rhythm. Premature atrial contraction. You have a P wave, narrow QRS, T wave is out of place. Makes it look like your rhythm's about to be irregular. Over here, on the second one, let's see, we'll list PAC, PJC, PVC. PJC, like we talked about, it could have a P wave, it could not. So you got heartbeat, 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 heartbeat. But right here, what don't we have? We don't have a P wave. It's still narrow. It's going to be a PJC. As far as your PVC goes, you got a beat that looks regular, a beat that looks regular. Got a wide beat right here. Anything that's going to be wider than 0.12 is going to be coming from the ventricles, which is going to make it a premature ventricular contraction. Ventricular rhythms. We have idioventricular, which is widened QRS complexes at a rate of about 20 to 40. We have monomorphic VTAC, which is going to be identical complex ventricular tachycardia. Polymorphic VTAC, which is also known as torsades de pointe, which shows a bow tie look on a monitor that we'll go over. And then we have ventricular fibrillation, which is going to be a chaotic vibration-like line on a cardiac monitor. So up here at the top, this is that Y complex we were just talking about. That's going to be your idioventricular. And then a 6-second strip, you got between 2 and 4 R waves. So you're going to have a beat of 20 to 40. Your monomorphic VTAC is going to be over here on the top left. Everything looks the same. Your polymorphic VTAC, which is that bow tie look we were talking about, is going to be this one right here. As you can see, you got points, it kind of gets narrow right here, kind of like it almost ties in, and it flips. Your points go up here. It ties in again, it flips. Your points go down here again. V-fib is going to be like this over here. It's going to be that squiggly looking line. It's going to be chaotic. It's going to look all junky, and that's going to be, these are going to be more or less some of your lethal rhythms that you're going to have to face out in the field. Stable and unstable VTAC with a pulse. Sometimes you can be presented to a patient who is currently in VTAC with a pulse at their own home. Treatment for these patients is going to consist of using an amiodarone drip, of taking 150 milligrams of amiodarone, place it into a 100 ml bag of saline, and infusing the drip over 10 to 15 minutes. With an unstable patient, you will use 200 to 360 joules under cardioversion. With an alert patient, if you have monomorphic VTAC, which is all the same, we're going to use synchronized cardioversion, sync up with that heart, shock it, hope it goes into a good rhythm. If it's polymorphic, you're not going to be able to synchronize with it, so you're going to use unsynchronized cardioversion on those patients. Asystole is going to be a rhythm you will find when there is no mechanical, no electrical functioning of the heart. When this rhythm is recognized, it is important, if the patient is viable, to initiate high quality CPR. And if you are a paramedic, always remember good BLS prior to ALS interventions. You can't be a good paramedic without good basic skills. For treatment of a systole, first thing to do, initiate high quality CPR, 30 compressions to 2 ventilations. Acquire an AED or monitored defibrillator as soon as possible. Make sure you perform 2 full rounds of high quality CPR to be performed before ALS intervention is began. So when starting ALS interventions, after you've had those 2 rounds of good BLS, you're going to follow your ACLS protocol. For ACLS protocol, your first line drug is epinephrine for asystole, which is going to be your Epi 1 to 10. That's going to be found in a vial. You're going to give the whole 10 mLs. Or if you got a shockable rhythm, you got 300 milligrams of amiodarone, which is going to be your loading dose. And then you can give 150 for refractory, which is going to be any shockable rhythm that pops up after you've given 300. If the patient is in torsades, then the medication of choice is going to be magnesium sulfate at 2 grams via IV push. Defibrillation of shockable rhythms, such as VTAC and VFib, is when they're noticed on the monitor. The paramedic on scene is to follow ACLS protocol as to properly administer defibrillation to the patient at the recommended shock settings of the monitor. Post-ROSC treatment. Say you've worked this cardiac arrest, you've gotten a heart rate back on this patient, and you made sure they had a pulse, you made sure they weren't in PEA, which will be one of the many rhythms that we saw earlier, but you don't have a pulse with it. Pulseless electrical activity. We're going to say we got ROSC on this patient. We have a pulse, we got a heart rate on the monitor, we got a rhythm on the monitor. Now it's time to make sure that this patient stays up, they don't code again on us. So, in some instances, once ROSC has been achieved, you may have to pace a patient, which you've already got defib pads on the patient. So, maybe you have to keep their heart rate up so their heart rate doesn't drop too low again. So, what we're going to do with that is, you have a pacer setting on your monitor, you're going to hit the pacer, you're going to place your hand on the patient's wrist, make sure you feel the pulse. You're going to turn up your milliamps until you see a wide QRS complex come up. That means you have electrical capture. Well, once you have electrical capture, make sure that pulse and that electrical capture is the same. So that way, when you hit that pacer again, it's going to keep going, keep going, keep going. Another thing, you have push dose epi, which is going to be used as a pressure in order to obtain a systolic blood pressure that is going to be equal to or greater than 90. And remember that you're still having to breathe for these patients, and after advanced airway placement, you are to breathe 1 breath every 5 to 6 seconds for the patient. In some instances, you may have to use different medications such as ketamine, fentanyl, or Versed in order to keep these patients sedated if they were starting to fight against the tube that has been placed due to the probability that the patient could go back into another sudden cardiac arrest if provoked too much.
$44 minutes and 37 seconds.